second panel, and I should just say that Yasmin Batawala wasn't able to join us today, so we're very grateful to you, Dr. Aaron Darnditlam, for coming to stand in at short notice for her. It's very kind of you. So, as previously, could I ask you to start by introducing yourselves and who you're representing today, starting with Professor John Strang?
Yeah. So, I'm John Strang. So, by background, I'm a medic who then became much more involved with university work around research and policy in the addictions field, and I've been sort of marinated in the addictions field for about 35 to 40 years now. And I head up the National Addiction Centre Research Group in King's College London.
I am Peter Yarwood, Exec Officer for Red Rose Recovery, which is a small charity in Lancashire aimed at creating opportunities for people who've come through services of the criminal justice sector and also substance misuse. I am the engagement lead, and I would say a driving force for the Lancashire User Forum, which is people who've experienced being on the receiving end of those services. As am I of one. I entered the criminal justice system as a child, a 15-year-old child, and then spent the next 20 years using those services.
Thank you.
Arun Dandaidam, I'm a consultant in addiction psychiatry. I've worked both in the NHS and the third sector. I'm a frontline clinician at Passmore's House, which is a detox and rehab unit in Harlow. In my spare time, I'm also the joint chief executive of WDP and the medical director. So we provide substance misuse treatment across large parts of London and in Cheshire East, in Cheshire West. So we do community treatment, we do inpatient detox treatment, and we have service provision in prisons as well. And we also do interesting things with contingency management with Capital Card.
Thank you.
Hello, I'm Danny Hames. My day job is I'm Head of Inclusion, which is part of the Midlands Partnership NHS Foundation Trust. And we're one of the largest NHS providers of drug and alcohol treatment services across country and community and prisons. I'm here today representing the NHS Substance Misuse Provider Alliance, which is a collaboration of 15 NHS trusts which provide drug and alcohol treatment services in prisons and community across England. My background is I've worked as a practitioner in drug and alcohol treatment services, a manager of services in various locations around the country, and now I'm fortunate to have the role as Head of Inclusion. Thank you.
Well, thank you all for coming today, and we're going to start off with treatment, and Paul.
Actually, Angela's going to do it because I took her questions last time.
Yes, Angela.
So, back to you. What treatments for drug addictions are the most effective, in your opinion? I'll start with Professor Strang, please.
I think it is useful to look at addiction problems that people have by the different types of drugs or classes of drugs that are there. Probably an early distinction that needs to be made is between emergency management of crises and the treatment of somebody's long-standing addiction problem, in that you've got completely different types of interventions. So you were hearing earlier about naloxone interventions to deal with overdoses. Those don't address the long-term addiction problem, but they're absolutely crucial life-saving interventions for the emergency. You also heard about the treatment of co-infections, HIV or Hep C. So when you're looking at your drug-using population, there will be a section of that population who've become dependent on those drugs, and that's your main treatment group. So it's first of all an acknowledgement, as with alcohol, there will be a population using where your dependence-related treatments aren't applicable, but then there's a population where they're hugely applicable. In that field, the strongest evidence with the illicit drugs is around heroin addiction or opiate addiction, where with opiate substitution treatment, so that means methadone maintenance treatment or buprenorphine maintenance treatment are the two main types. Those have now got a very strong and well-recognised international evidence base, particularly generated by the US over the last 50 years or so.
Okay, you mentioned there that an example of an evidence-based approaches to heroin. To what extent are the current drug treatment services evidence-based, and what barriers are there to delivering evidence-based treatment, in your opinion?
Well, the documentation that we have in the UK, both at a sort of government policy level and from a Department of Health level, looks quite good and encouraging in that for many decades now we've identified how crucial it is to have good quality opiates. There are various different acronyms. So there's OST, which is opiate substitution treatment, or there's maintenance treatment. They're all essentially the same. The acronyms go in and out of fashion. Unfortunately, the reality of our provision of it is that a lot of the opiate substitution treatment we provide, I think, would be regarded as quite low quality on a number of measures. Some of them being very practical, concrete measures, like are the two main medications, methadone and buprenorphine, are they prescribed in the dosage range that's regarded as optimal dosage range? Is there then the proper monitoring and support to check that you get a good adherence to it? And is there the psychosocial support and counselling which increases the engagement and the benefit? And on all three of those, the picture is much worse. So most of the prescribing we do is probably below the bottom end of the recommended dose window. There's a diminishing investment in helping make sure people get engaged with the treatment. And as with any treatment, if you aren't taking it, whether one goes from treatment of your hypertension or the contraceptive pill or any of these things, if you're not in a routine of taking it regularly, you're not going to get the benefit from it. So we have a lot of low-dose prescribing. I think it's fair to say, mindful of the questions you had earlier, I think some of that is driven by misguided targets that are given to treatment agencies through the commissioning process, where there's an effort to get people at the earliest opportunity off their medication, whereas what we should be doing from a health point of view is individualising people's treatment. And of course we don't want people staying on treatment at a time when they can safely come off it, but we need to be aware that coming off the treatment prematurely carries major risks. It carries overdose risk, it carries infection risks if you relapse to your injecting.
Okay. Peter, Danny, or Dr. Aaron, would you like to add to that?
First, the good things, I suppose. We have very sensible guidelines in the UK. We're all led by the Orange Book. There is robust guidance out there about what constitutes good practice. We are holistic, we are recovery focused. But like John said, our KPI, as in terms of barriers, our key performance indicators, are in a sense weighted against what the clinical evidence would say. So we know people do well when they're in contact with the treatment system, they don't die. However, our performance indicators would say you need to exit people out of treatment, or we will penalize you by payment by results, and your funding can get taken away. Our funding is also is reduced year on year on a background where actually the costs of providing these services have increased. The prices of our key medications in OST, as John mentioned, we've got two main drugs. The price of one of them has increased close to 500% to 600%. This is something that treatment services can't afford. Again, we're also hit with two other additional double whammies in that the complexity of care that we now provide was unimaginable 10 years ago. So what we're being hit with is a cohort of patients that's aging. With your aging, they come with now a range of illicit drug use, prescribed medications. Their physical health status is declining because of years of smoking, hypertension, diabetes, obesity. They're then getting into old age illnesses with their brain, alcohol-related brain damage, dementias, loneliness, anxiety. And this is on the back of a workforce where the skills have been steadily decreasing. So when I started in addictions about 10, 15 years ago, there was a strong pool of doctors and nurses supported by a wraparound team. Those consultants and addiction psychiatrists have vanished, and they've been replaced by what you call lead clinicians. The lead clinicians have vanished, and they've been replaced by staff grade doctors who call lead clinicians. Those staff grade doctors have disappeared, and they've been replaced by nurse medical prescribers.
And we're going to come on very specifically to look at some of the workforce issues around this later.
We have a problem recruiting staff. We have a problem with staff having the right skills. And we have a problem keeping them in the sector because of a high burnout rate. It is a very stressful sector to be working in. So I think all of these constitute difficulties in providing what is actually sensible care.
Okay. Do you have anything to add?
I think there's a bit of a disconnect between the services and the communities they serve in some cases. You know, I come up against service users quite a lot, and the first thing they want to celebrate is the fact that they're coming down the table in their medication, they're getting off it, and when I ask them, have you managed to secure decent accommodation yet? And the answer's often no, I'm still in supported accommodation. Have you secured employment yet? No, I'm not employed, I'm still claiming benefits. Their recovery and social capital is in no way aligned to, you know, this drive to exit treatment, and I just think some of the resources where it's worked well has been ploughed into bringing the service users and the community with us on this journey.
That's a really good point. Just moving on slightly, I'm conscious that Danny will want to come in as well, but around the balance between substitute prescribing and abstinence-based recovery, where do you think that balance should lie? Maybe I'll bring Danny in first this time, if that's okay.
I think really to just track back, one of the I think most damaging narratives that's occurred in the drug treatment sector has been this quite polarising debate between abstinence and harm reduction. And I actually think that in terms of that question, I think actually the balance is defined by the individuals that we are working with. And I think sort of really to track back to the previous question is we have the guidelines, predominantly we have the evidence that say if you provide a system this way, it will function well and it will give most people the best chance of achieving what they can. So for some people that will be abstinence, for some people that will be different improvements, but their life will improve. So I think to say where the balance sits is actually it needs to be defined by actually how we construct and commission our system, and actually the way that we commission services currently, and that's not just for drug and alcohol services, but across a range of other disciplines, criminal justice, etc., all causes fragmentation, which then when you get to the point of delivery of a service, means that actually providing a service in a way which is integrated, so to the end user you provide that service that provides good quality pharmacological interventions, good quality psychosocial interventions, and then wrapped around that good social recovery focused intervention peer support. That's what really defines where people get.
Okay. My last question is specifically around opioid substitution therapy and whether it's currently adequately provided. But I think Dr. Strang, or rather Professor Strang, you referred earlier to the low quality and the maintenance. Is there anything else you would like to add to that point?
Yes, it's probably worth pointing out that they're not particularly opinions that I've got. I'm just sort of factually telling you what the records say has happened. So the amount of opiate substitution prescribed over the last 10 years has reduced by about a third, whilst we're told that the treatment population or number of people deemed requiring the treatment has remained constant. So those two observations need to be sort of brought together. And there's definitely been this, from one point of view, a well-intentioned wish to encourage people not to stay in treatment if treatment is not necessary. And I mean, that would be something that's pretty universal to medical practice in general. You don't want somebody to be on treatment if they don't need to be on treatment. But it's been made toxic by the fact that it's been wrapped into performance targets with competitive tendering. So you win your competitive tendering exercise by giving a commitment that you will exit people from treatment with a higher rate than a different organisation. That leads to the wrong sort of work in people getting out of treatment. And we need to realise that coming out of this treatment isn't neutral. Coming out of this treatment has, when you should still be in it, has real hazards. And I think it's where a health orientation is quite a comfortable territory to understand these issues. There are many examples, so it's not even worth going through the examples. There are many examples in healthcare where you would not want to be giving the chemotherapy any longer than is needed, but you don't want to cut it off shorter than it needs to be, and it's a difficult judgment. So the short length of time, so Professor Hickman was referring earlier to the study of GP prescribing where there's healthy data set through CPRD data, and the disturbingly short duration of opiate substitution treatment means that you have the destabilised bit at the beginning and the destabilised bit at the end, with people recycling through it, and that's a hazardous way of providing it. And as you're quite rightly saying, the lack of ancillary support, the lack of attention to the housing. Dame Carol Black's report from a couple of years ago was talking about the fact one should be able to, what you would want within treatment is to be able to prescribe employment opportunities as well, to be able to prescribe other things which were essential components of what you were giving to somebody as part of getting back into it. That's almost non-existent.
But I think, to be slightly positive, I think that part of my role is I'm quite involved in a lot of the sort of tendering of services. So I've got a sort of 5-6 years experience of seeing drug and alcohol tenders. And what we are starting to see now is a trend away from that very sort of, it's very much about successful completions recovery, because I think it's now starting to filter into the system that actually that is not a helpful barometer, and it doesn't actually help service users. So I think that is positive, but I think what it illustrates is the fact that we've had to get so far down the line, so many years on, and we've had these sort of perverse consequences of what was, I think, probably a well-intentioned decision. But only now, I think, are we starting at a local level for commissioners to start to say, well, actually, we can commission in a different way. And I think there's a significant damage because of that.
Can I just clarify, because Aaron, you were saying that funding's being taken away if people aren't exiting treatment. Is that happening all around the country, or is, Danny, your experience that there's a great deal of variation with sort of changes with people recognising the evidence base is completely the opposite?
I think in terms of using payment by results as a measurement, I think there was a push towards that probably 2-3 years ago. I think it's generally proven not to be successful, and actually if you look at the trend in terms of successful completions for opiates, this is I'm not saying it's a direct correlation, but actually that trend has been down anyway. So I think in terms of a PBR as an approach, I think we are starting to see that much less.
You're starting to see it. Does that mean that some areas have abandoned it and some areas haven't?
You've got such variety across the country and such different commissioning cycles. You can only really see the general trends.
You can't stop it halfway through a commissioning cycle. You can't say, look, there's no evidence for this. It's actually actively leading to more people dying. Because in most treatments, if you could see there was evidence that people were dying as a result of your policy, well, you'd stop prescribing the medicine. But we're still prescribing something that's actively.
I think theoretically, you can, in terms of contractual arrangements. But I've never experienced that.
Why isn't somebody taking responsibility for saying there's clearly evidence? I mean, everyone seems to be agreed that this is killing people. So why isn't somebody doing something now to say we've got to abandon this?
I know, it's a good question.
But who would be directing that you should continue?
Well, I think at the moment what we have is because the way the system is commissioned. So we have, as you know, we have local authorities, public health teams within local authorities commissioning separately, and within that you see great variation in terms of, I think, the influence of public health within a local authority and where a director of public health will sit, and thereby influence over that sort of area. And I think, so firstly, you've got that. Then I think Public Health England I think has sort of worked hard to try and influence local authorities in the system. So for instance, I think the current opiate substitution therapy sort of best practice program is an attempt by them to actually say this is best practice in terms of prescribing to influence local authorities. But I think the issue you have is you have no really direct leverage between the centre, if I could put it that way, that says this is best practice, this is the way we should administer it, and the local authorities who we know are under extreme stress in terms of their budgets.
Is it not extraordinary that you've got something that's actively, nobody disagrees that this is actually killing people, this approach, and yet I'm just trying to sort of see if there's a consensus here about who could actually step in and say, this is a harmful approach, it's killing people, therefore we stop doing it immediately?
You think it's extraordinary. I think in when we had the National Treatment Agency, I think that's the role an organisation like that would have been able to influence and taken. I think without that specialist arm's length agency, we lack that sort of direct influence.
So it's the lack of that direct.
That would be my opinion.
What do you feel, Professor Strang?
Yeah, I think was an unfortunate move of the commissioning of services outside the health arena, because it means that, for example, reference sources like evidence from NICE doesn't carry the same weight with a local authority that it would carry with a health commissioner.
We have directors of public health, we have Public Health England. Should there not be an immediate, as we would expect, for example, if we knew that there was a direct harm from a drug being prescribed, there'd be a directive to say you must stop using this treatment. Should that come from Public Health England? Who should be issuing that directive so that this was immediately reviewed?
Yeah. I'm not sure who should be issuing it, but there isn't, when you say, so I'm not sure what the answer is, but I think the question is the right question, because there should be somebody who both has responsibility for it and the ability to issue that statement. I think Public Health England's response, when I've had similar conversations with them about various issues, is that these decisions are devolved to a local level and local decision makers make those decisions. And my own view is that, along the lines of what you're saying, there are some points that are not matters of opinion, where you're seeing whether somebody likes the mix of this or that within the treatment, but they're evidence that you're wishing to implement.
Yes.
And I think it would be very good if there were ways in which you could require there to be a process whereby those sorts of decisions could be made centrally, and then the decisions about implementation are, of course, local. The system, picking up on some of your questions earlier about drug testing in festivals and such, I think it's important you understand how stripped down treatment services are. Treatment services around the country do not have drug testing in the treatment services. So quite apart from an additional service to people attending festivals, you don't have a surveillance system within your treatment system about whether your patient is doing well or is slipping back into drug use. Colleagues would probably be able to give answers, but drug testing is very infrequent, and it's one of the other short-sighted ways of saving on a budget when you're trying to put in the most competitive price. What you would want, rather...
When you're talking about that, you're talking about testing whether people are still using drugs in addition. You're not talking about people bringing in their own supply of drugs and saying...
No, oh gosh, I wasn't talking about anything as ambitious as that, no. So there are two things you would want to know. If somebody comes in and says, I've got a major heroin problem, I need help getting to grips with this because I want to get out of it. You want to know that they're taking the medication you're prescribing is one way, and you want to know, is there anything else in their urine sample which shouldn't be there? It acquired a bad reputation because treatment services mistakenly used this punitively to throw people out of treatment years ago. What it should be used is in the same way as if you would check with your diabetic whether they have sugar in their urine, or one other examples where you'd be able to say to somebody, we've got a problem here, how do we alter what we're doing because we're not achieving what we're meant to achieve. To do that without the laboratory backup, it is possible to do it, but it means you're working as a clinician with one hand tied behind your back. And the objective, rather than wanting people to exit treatment, the objective is you'd want them to be exiting the street drug use they were involved with. So you'd want to be sure that they were not showing heroin in their urine, for example. And if they were then tapering off to reduce, that would be good news, provided you still had the negative urine specimen.
Thank you. Paul had a...
Yeah, I just want to check what you're saying here, that the tendering out of services is meaning that providers are putting in bids that are more competitive, but the quality of what they're doing, of what they're offering, because of the whole process. So it's not that it's their preferred model. They are putting in bids and winning contracts with services that are much lower quality than they should be, and are not following the best evidence-based management regimes for the patients or clients.
Well, I would have thought that it's a sufficiently important issue. You might want to ask through various channels for people to provide you with that evidence, but rather than me giving you the view that I have, which is obviously skewed by the colleagues that I've spoken to who've described different situations. But the reduction in the funding of services is public information and would be quite easy to collect, and I think would show that it's reduced by about a third. Sorry?
Yeah, 28%.
28%. Okay, so I'm exaggerating when I say a third, but not by much. But I think you'd also want to look at, are there aspects that clinically you would have thought were critical, which are now only used infrequently? And you'd have to make a decision. How frequently should urine testing be done? Should it be every fortnight, perhaps? I'm not sure, but
and this has happened.
That could be provided to you.
And this reduction in quality of services has happened at the same time as drug-related deaths have increased.
Yes, and that's a point that Professor Hickman referred to an editorial we have coming out in Lancet Psychiatry, which points out that the timings coincide.
And is there any, there's an association, there's a temporal association, is there any suggestion that one has caused the other?
Well, we can tell you that the timings look very similar. And if you ask what would you worry about if you were stripping out those elements from the service, and if services were becoming over preoccupied with getting people off their books, your worry would be that you were placing people back in a vulnerable situation again with relapses and with overdose deaths. So those are precisely what you would worry might occur.
Do you think that the cuts have caused an increase in deaths?
I think it's disappointing that it's not one of the, in the considerations of possible causes, which include an ageing cohort. And, a number of us have made before is the cohort is only ageing by 1 year per year. So it isn't that the cohort doesn't get suddenly old. So it doesn't account for rapid changes.
Do you think the cuts are causing the deaths?
I think that should be considered much more actively as a cause. And you could look at what happens in parts of the country where that's been moved faster or less. I'm not aware of that having been examined.
Thank you. Diana had a question.
I just wanted to follow up on the issue of commissioning, because we've talked about cuts to the budgets, but it seems to me from what's being said that there's an issue around the quality of the commissioning that's taking place. And I wondered, well, this is to Professor Strang, is it that you think because it's a local authority function, they don't have the expertise, the knowledge that you would find if it was being commissioned in the NHS? Is that what you're saying to us? There isn't that within local authority commissioning units?
I think there's probably two aspects. So one is whether a local authority group or a public health group or a health group would be a better commissioner. I think it depends very much on who you have in your local area. There are some excellent local commissioners. I think I'm more struck by the point that the chair was making, that would you not expect a system where there was much more given instruction from the centre about what it was that was to be commissioned, whereas at the moment it's more open than it ought to be about what should be commissioned. So if you said we think that for an area with your population and your level of deprivation, we assume you would have treatment capacity for so many hundreds, or and then of course you adjust that according to what you have as your local problem.
Okay, so you don't think there is particularly an issue around quality of commissioning?
I think there are major weaknesses in the quality of commissioning. I'm not saying, the point I was making is that's not universal. There are some very good commissioners, but there are some very poor decisions made.
And the way you get around that is doing much more from the centre, telling people what they should or shouldn't do.
Yeah, and it's disappointing because when I said at the very beginning that the documentation we have and the structure we have are fairly good. I mean, various of us referred to the Orange Guidelines and such. It's a weighty document which I shall leave behind with you. And there's only a small number of collector's item hard copies, so I shall leave a hard copy with you. But they're aimed at practitioners. They don't do original research. It's essentially, it says, here is the consensus of what guidance and research documents from around the world have said applied to a UK setting. And it's the implementation of those consensus guidelines documents that seems to go badly wrong in that final stage of the commissioning. I don't know whether my colleagues differ.
Clarify one point though.
Yeah.
I mean, within the Orange Book, does it actually does it refer to the evidence base about not having an abstinence, exiting people from treatment programs? What does it say in that about that in the Orange Book?
I mean, I'd have to check for if you were wishing to know exact chapter and verse. I'd have to check on it. But it basically says there should not be fixed time limits on treatment.
Right. So it's quite clear in the Orange Book.
Yeah.
But local
and the
areas
optimal dosing is quite clear in the book, and the attention to helping somebody get established into a pattern of good adherence to their medication. They're described at length
What about, I mean, obviously another area that's come up is the role of heroin-assisted treatment. I mean, which of the panel would like to talk about heroin-assisted treatment and what the role is of that in the mix? Would any of you like to talk about that in particular?
Sorry, okay.
That's true.
I was wondering if any one of you feels you have would like to particularly address that.
I'm not wishing to hog it. We did a Ben Bradshaw was asking earlier about, do you have randomised trials of things? We actually have a randomised trial of heroin-assisted treatment that we did in this country. And just to be clear, I think it's a really small element of the treatment commissioning that's required. So this is not a major aspect of provision. It's for the very most severely entrenched heroin addicts that everything else has been tried many times and there seems to be no traction on their problem. And the Swiss took the old British system of pretty unregulated heroin prescribing and tightened it up into a very supervised form of treatment. And that's become the model for what half a dozen countries around the world have now done trials on. And the conclusion is, for this small group, if you are willing to invest the greater intensity of services and the costs that go with that, you can turn things around for about 2/3 to 3/4 of them, so that they move away from their entrenched street heroin use and begin a much healthier recovery journey. That's a treatment cost which is 3 to 4 times what the ordinary treatment cost is. But it's actually a cost-effective approach compared with not doing it, which is even more expensive.
Yes.
And we can send various papers documenting it. And where I say the documentation is good, the Department of Health, the government's drug strategy report of, I think it was 2010 or 2009, I can't remember which it was, concluded that if the trials found positive results, then there should be commitment to a small capacity of this, bit like intensive care in the community. You know. And that's there in the document, and Department of Health then commissioned a small number of such clinics until about 4 years ago, when, with the next wave of reduced funding, it was devolved to a local decision-making level. So local decision makers were told, you have to make a cut, and you also now have to make the decision about whether you keep this expensive treatment in your locality. And all 3 of the pilot clinics that had been set up were casualties of that move.
Even though there's a good evidence base and it's cost effective, they've discontinued that.
Yeah.
And yet there are other treatments that we know that are harmful, other approaches that are harmful, that we're continuing with.
Yeah, and the papers around the world, they're about as good evidence as you could imagine. They're well-designed studies. They're published in Lancet, BMJ, New England Journal of Medicine. So it's not in the South London Chronicle. I don't know if there is a South London Chronicle. I don't know if you know, but and also cost-effectiveness analyses. But it involves a different mindset, where you want your commissioner to realise, we don't think that's our main treatment provision, but for 4 in 100 or whatever the calculation was, we realise we'll need that intensive treatment, and we hope then we can make progress with them and move them back into more orthodox treatment.
Thank you.
That's what the 3 pilots were, the 3 pilots that you mentioned.
Yeah, so one was in South London, one was in Darlington, and the other was in Brighton. And there's expected to be one opening in Glasgow probably later this year.
Thank you for that. And another area would just be helpful to have your thoughts on it, be the place of detox and residential treatments, where they fit into the pattern. Do any of you want to speak to that one at all?
I think it is an intervention, again, that benefits a subsect of our population. So, as the expertise in community services has declined, I think people have now needed to go in for an inpatient detox to get their treatment effectively. And they need to come off alcohol and drugs, and actually this can be quite life-saving for them. And of course, this carries a lot of risk, but it is expensive. As community funding is reduced, so the number of people that can then afford to be paid for to go into these units is a challenge for community services. They can't send through all the people that they want to send through. What's also happening is the number of units have actually declined significantly. There is now no NHS detox unit within the M25 area. And we've only had 2 in the London area. One was Equinox and City Roads. City Roads is just closed. We've got Equinox and Passmores in Harlow doing the detoxes. Again, very complex clients, but it is a treatment that works very well for a certain group of patients, though it is expensive.
I think the need for detox for the most complex patients is going to increase, and I do think there's actually potentially a risk which is on the horizon, which is quite significant, which was just referred to there, in terms of the sort of there's now 4 NHS inpatient detoxes left in England, and they are estimating that by 2020 they may have to close, because the reduction of funding which is coming through from local authorities, which is generally now given to service providers, actually to maintain those inpatient detox units which deal with the most complex people, you need 24/7 medically managed care, they're becoming financially unviable. So there is an increasing need for those types of facilities, but actually the way that we are structuring the funding and the way that they are currently organised means that those inpatient detoxes are at risk. And I think the point that was made there about there not being one in London is...
Can I just clarify, so the NHS ones are disappearing.
Yeah.
Is there still private provision that people
there is independent provision, but
yes.
And I wouldn't be able to quote, but a number of units which can deal with the most complex clients, and we're talking the people with the most sort of complex comorbid conditions. I think there's few left, but I wouldn't be able to quote how many.
Thank you very much. We're going to come on to sort of psychological services now, and Diana.
So I'd like to just ask you what role should psychosocial services play in drug treatment and recovery, and are there sufficient numbers of these available at the moment? Whoever'd like to start.
I think the provision of psychological and psychosocial services as part of any effective drug treatment system is absolutely essential, and it should be done. If someone's in receipt of pharmacological intervention, it should be done in conjunction with that. Is absolutely essential. I think theoretically, you would say that I would challenge really in any local authority area any service that wasn't commissioned, saying that was a central component of what's offered. I think the evidence around effective psychosocial interventions is there could be more investment in that, but I think the Orange Book sort of gives us good guidance of what's effective. I think one of the biggest challenges to it, and this sounds a bit like a broken record, is the funding reduction sort of means that actually the workforce, which is primarily there to deliver it, one I think is the number of psychologists within services is greatly reduced. I think the workforce that we have in terms of recovery practitioners and the training around them has been reduced, so our workforce has become less skilled, and actually those with psychology are our main proponents of psychological interventions or psychosocial interventions. So I think that's putting great pressure on the system. And I think we're going to talk about workforce later, but I think that's one of the big implications of that. There is, and I think we've talked a lot about sort of where there's treatment services not succeeding. There are areas where there's good practice around that. But the problem is we are losing the expertise who can then train the cohort of staff who engage with our service users to provide quality interventions. And numbers of staff go down, caseloads go up. So if you used to have a caseload of 30, you've now got a caseload of 60, which means you've got less time to spend providing those interventions. But it's essential to a successful system.
Is there somewhere particular that you could say is doing this very well? Part of the country or an independent provider?
I think I wouldn't be able to reference specific areas, but I think you can. We've got strong data sets, which one illustrate where systems are more successful than others. You know, we have that information now. It's a rough barometer, but it does give you an indication of where a treatment system is more successful. And also within NDTMS, you have actually got details of what areas are providing what psychosocial interventions. Now, I do think there are some data issues around that, but actually that can give you a guide to where an indication of certain specific interventions are being provided. And I think if you look at that in relation to how effective a system is in terms of completions, that gives you a hint.
Anybody else want to say anything on that? Or?
I suppose I could speak to the former question about commissioning, and in Lancashire it's working quite well because our commissioner's quite close to what's going on in the community, and that doesn't mean we have to present a set of figures based on KPIs that are sometimes unobtainable because the outcomes are really for the individual and they're very complex, and organisations that tender for some of these pieces of work are tendering in a competitive cycle, so it's not geared up for collaboration. What works well is where there's flexibility to actually meet the needs of the individuals and the communities and create real opportunities for change and to sustain that. So I would say there is examples of it working well and using principles of asset-based community development and co-production where we've brought parts of the system together. And in times of austerity, it's been almost like it's an opportunity to do things a little bit different and create opportunities for people who've existed on the margins and come to be all right with that. And we've said, no, that's not okay. You're just as worthy as everybody else. And we've created an opportunity for them to stand, shoulder to shoulder with other organisations, other providers and peers, and really make a difference. That creates a little bit of rub because stigma is real, but it affects the mindset of a group of people who have got no stake in society, and when they start to see visibly people from their communities progressing and doing well, it addresses some of them deeply withheld, them thinking distortions, and that's when that change starts to happen on the inside. So there is examples in Lancashire of where it's worked well, and I've got a staff force of 28 people. Vast majority have never had a job in their life, and they're making a difference. But they're not running around collecting KPIs. They're running around, and I suppose they're having purposeful and meaningful conversations. And we have had to crunch data. It is public money. We are accountable for it. But I don't know many places where people who've been perceived as the problem have been given an opportunity to have a go at becoming the solution. And I suppose that's got to be part of it.
Thank you.
I think, I think what will be helpful is Dame Carol Black's review, which has been prompted by the Home Office, because part of what she is doing is actually visiting treatment systems that seem to be working well, and I think that will give us some helpful information.
So can I just move on to ask about contingency management work and whether that should be used more often in drug treatment?
Right.
And perhaps someone could just explain this to me, because I read what it was in the brief, but it sounded a bit... I wasn't quite sure. You're giving money to people?
No, well, yes and no.
Okay.
What it is contingency management is a kind of behavioral therapy. What we're trying to do is reward people for positive outcomes or positive actions, and we're trying to reward them as close to the positive action as possible. So there's no punishment here, and it works very much like a supermarket reward loyalty scheme. You get more points when you go in. So what we've done is we've recognized the problems facing our sector, sometimes the lack of effective psychosocial interventions, these high caseloads, and we've come up with something called a capital card. So there have been previous barriers to using contingency management. There's a huge evidence base. We know it works really well. But some of the problems have been a lack of understanding among staff as to what actually contingency management is. We've tried vouchers in the past, but then you have headlines in the press screaming junkies being given money. And then the third problem you've had is there haven't actually been that many interventions that you can easily pick up and use. So we've tried to address that with what we call the capital card. So we give all our service users a card. When they come in for their appointments, they get points. When they come in for group work, they get points. When they get their hepatitis vaccinations, they get points. We're rolling it out so when we tell them they have COP, a chest problem, and they go to their GP, the GP can let us know that they've had it checked, and we give them points. And they then spend these points at a whole network of providers, both nationally and locally. So they can then redeem these points at our local upcycling furniture stores. They can actually go into Nando's and have discounted meats. So these are corporate partners. They can go into football clubs and have special sessions there, music lessons with CityLit, so they can have almost access to 7,000 courses online. But the more important thing that it actually does is, one, a lot of our patients have never saved or spent anything before. It connects them back with their community. So they're back in with their hairdresser saying, can I use my points for a haircut? And what this is in one or two instances led to is actually the hairdressing salon saying, you know what, now we have a relationship, do you want to apprentice for me? And they've gone on to careers there. So that's kind of the way the capital card works.
Is that quite unusual though?
I think in the sector, we're the only ones who have a supermarket loyalty type provision. It is quite cheap. I mean, it didn't cost us much money at all. And we are looking at developing this for other behavioral change, because weight management, smoking, mental health, there are implications across for actually rewarding people for positive change. And it connects to the 5 ways of well-being. So on the case system as well, when people spend their points, you can see whether they're using it to connect with their community, exercise, diet. You can see what they're actually doing with your points.
Can I just? I think you can make a connection between the 2 points you've just received, in that whilst my examples earlier were very concrete things around the medicine and the medication and how you could measure it, that has the advantage of being easy to measure, so you know whether people have or haven't done it. But I think the content of what's being provided, the intention is that there should be much more of what you were describing about the wider holistic care and the examples you gave. It's a huge challenge to say to somebody, well, why don't you go and get a job? You go, well, actually, I haven't ever had a job for the 18 years since I dropped out of school. I'm not really a very employable person. It's not an easy step. So you've got to do a lot of investment. But the other point about the contingency management is that you can work with this patient population as you can with the rest of society, and you discover our behaviour can be shaped and nudged in particular directions. And there's a strong US research evidence-based studying voucher reinforcement or contingency management, and there's now there's a small number of UK trials. So we looked at people's hepatitis B vaccination completion. You can convert that from 9% completion rate to 45% completion rate with, I can't remember if it's a £5 voucher or a £10 voucher. I'd have to go and check. But you think, so behaviours are shapeable, and if we think of it as an intervention in our toolkit, it should be a number of interventions that we realise can be social interventions that you can still plan to deliver. Yeah. And Dame Carol Black's earlier report, so not the work she's doing at the moment, but a report came out 2 years ago, as I say, wanted work to be something that you could give a small dose of and then allow somebody to build up their capacity with it. And at the moment there are some pilot schemes looking at building work into helping people's recovery, and we're waiting to hear the results from those.
Without, I suppose, more sort of defined suppose I describe them as quality standards about what you would expect as a core component of a treatment system. You are reliant on local providers or different organisations to develop an intervention like that or not. And when you have a diminishing pot of money, if you don't have those sort of core planks that say you have to do it this way, each provider, often in good faith, will decide, well, how do we spend the investment that we have to get the best effect we think it will get? And it really does depend on the skills and expertise of the organisation doing that, paired with the skills and expertise of the Commission. And it's, you know...
And the community as well. We and the community, the skills and expertise of the community. It's often the piece of the puzzle that's left behind. And we flipped it on its head and started to look at our service users as gifts and started to have those conversations as well and challenge their internal conversations, which will amount to, I'm worthless, you know, some of the colourful language, what's used to describe our community, will directly challenge that. One of our examples is time credits. So last year we contributed 10,000 hours worth of volunteering. That as an economic figure equated to living wage. You know, you can add it up, but the difference that made, that it's really difficult to measure, because we're connecting our people who have been on the margins, we're connecting them in with local churches and faith sectors, parts of the community that aren't beholden on the stroke of a commissioner's pen. And they're the real things what help people get and stay well.
I think it's this is where the stigma is just so fundamental, because you have the treatment provider, then you have the community, the sort of peer community wraps around them, and for it to be successful, they all need to knot together. But then you have the broader community, and I think what we've been listening about is examples of how people in that peer community who have lived experience, come through services or not, actually mechanisms to connect them with their broader community, so it starts to challenge the perception of people who use drugs or use alcohol. And it's that then starts to unlock the doors towards employment. It starts to happen housing. It builds social capital. And without that part of it, we have a system that sort of sits separate. And you need that sort of bridge.
I think you've just answered my question.
Thank you. Do people who use drugs receive adequate mental health services?
Oh, you don't.
No.
Why not?
So, previously, I think, there was sensible dual diagnosis strategies in that people with low-level mental health needs were managed within substance misuse services, and these substance misuse services had psychiatrists, had qualified doctors, nurses, who knew how to look at a patient holistically. They had the skill set to do that. And then the more complex patients went to the mental health services, to community mental health teams. But it was always a challenge. Even then it was a challenge. But what's happened now is the skill set in substance misuse services has decreased, so we can no longer hold on to those even low-level mental health problems that patients have. But then the threshold for actually referring people into community mental health services has shifted upwards as well. So there's a whole group of patients in the middle that can't actually access mental health services unless if it's in a crisis or through their GP.
And are IAPT services appropriate for this group of people?
It's very variable across a patch, IAPT services. Some IAPT services will take patients who have substance misuse issues, but a majority of them will not.
Yeah.
So our patients can't access it.
We're talking about people with anxiety, for example, aren't we? Or depression. But you're saying that there are some counselling, psychological services that won't take an individual with depression, and is that possible?
With substance misuse issues.
Yeah, they may well be using substances in order to self-medicate their anxiety, but because of that, and are they allowed to do that?
Yeah, it's for a number of them, it's listed as one part of the exclusion criteria that you're not eligible for IAPT.
So does that mean that the commissioner who has commissioned that service with the exclusion criteria has a legal responsibility to commission an alternative service so that that problem will be treated?
That's a good question. I don't know. But just to check, you picked up on the point that my colleague was making, that this would have been seen as part of what addiction services or substance misuse services provided, because they were led by and staffed by people from people who trained in addiction psychiatry, mental health nurses, mental health social workers. You had people who saw a broader mental health disorder as part of what they were familiar with working with. And that would always have been part of what addiction services did. We've now gone down this over-specified commissioning, so you will have people with a comorbid mental health problem being told that can't be managed within the substance misuse service because we only deal with your substance misuse.
Do most people...
And you go, this is ridiculous. This is sort of part of what someone's problem is.
Do most people with substance misuse problems have a mental health issue?
Yeah, it depends. It depends where you put your cut-off, but it's very common for there to be, coexisting mental health disorder of some sort, and it makes the management of the totality of their problem more complicated. And it's how in all areas of medical practice there are some simple cases and then there are some trickier cases, and you use your workforce appropriately, to work out who's treating them. But I think across the country it's been a problem that those have become separated, as if the coexisting mental health disorder is a different specialty, and you sort of think, well, it's actually all part of managing mental health disorders.
I think, and one of the unintended consequences of the tendering of services and the fact that there are now less NHS providers, because what you would have had is, in an area, an NHS mental health provider often providing or having a role to play in the provision of mental health services. The number of NHS providers has greatly diminished. So what that's led to is, and I think the over-specification is accurate, but basically organisational barriers as well between the local NHS trust and the local independent provider.
What needs to be done to address this?
I think it's, I think that we talked earlier about sort of should this be commissioned by the NHS or by local authorities. I actually think what would be a preference is actually looking at how we co-commission between local authorities and NHS, because actually the way that services commissioned encourages separation, and when you have organisations competing against each other, there's always a white elephant.
There should be so the CCG has a responsibility to provide for the physical and mental health needs of those patients, primary and secondary care physical and mental health needs. The local authority has the responsibility to commission substance misuse services, and you'd say that if they got together... I
think a mechanism that made them both responsible for commission of drug and alcohol services would greatly aid a lot of the sort of...
Is that happening anywhere?
Not that I know of.
Why not?
You'd have to ask the local authorities and local NHS that. I think it's generally organisational boundaries. I think everyone's sort of got a lack of funds.
I mean, there are some instances where there's been co-commissioning and it's healthier, but personally, I think you have a stronger system if you have a 51% responsibility in your health arena. Clearly, you've got to be massively working with your local authority partners, given the nature of what you're wanting to do. But it's lost its connection to health, and it's lost its imperative in the public debate. So if you look at the public debate in the UK versus the public debate in the US, for example, about how to respond to the opiate problem, the US is wanting to make sure there's wider provision and addressing coexisting health problems with a commitment much greater than we have here.
With co-commissioning, presumably you end up getting two different commissioners, but perhaps one provider providing the substance
Or a
misuse?
consortium provision. I mean, I think probably the strongest models that I would see is where in a locality there's been a consortium approach to the provision of the different types of interventions you want. But that involves really strong leadership, because all of the competitive tendering process divides you. You know, and it's really difficult to do a consortium model when you know that any one of you might take the plans that seemed rather good and submit them in a single provider. But there are a few examples which work well.
I mean, nobody's talked about general practice, about primary care for this group of people, because usually when you have a high-risk, vulnerable population, their access to and the quality of their primary care is essential. But my experience is that if this population of people exist within routine primary care, then their outcomes aren't even measured. Their primary care, they're not seen as a distinct population whose outcomes are measured within primary care. Is that? I mean, are there any good primary care models for this population of people? Because the mortality isn't just because of the substance misuse. The mortality is often because of other issues that could be better managed.
I mean, we have a much healthier system in this country that it is broadly accepted by most primary care practitioners that it is within the scope of responsibilities, even if it's an unpopular bit of the responsibilities. So that puts us ahead of a lot of other countries where it's completely ghettoised as being only in that special area.
Inverse care law will tell us that these people are the people who are least likely to attend for screening, least likely to have well-managed diabetes, least likely to be immunised, all of the basics.
Unless you've got an interest in them, they may not be a rewarding patient group. And so I think probably there's quite a lot of provision that is done to be adequate, but probably not with the extras. I think a lot of the third sector provision has been a hybrid of GP provision where GPs are brought in as sessional task, and it's a tricky one. Is that what one meant by primary care provision, to be doing sessional work in a third sector agency, or did one actually think that it was integrated into the broader provision? And that's probably a different debate.
There is a diminishing number of GPs interested in substance misuse. So there's you've got the RCGN, the Royal College of General Practitioner qualification, I think level 2, which is a qualification of substance misuse. The number of GPs going through that is reducing. So actually, and that's detrimental, because we need those GP advocates within surgeries advocating for our clients. But those numbers are diminishing, which is worrying.
I think going back a few years, shared care was quite popular. We had a lot of shared care schemes where you'd have the consultant psychiatrist in the services supporting and mentoring a range of GPs in GP practices. We'd stabilize the patients, we'd move them onto the GPs, and it was okay for them to have a prescription and to maintain a quality of life. But then we've moved away from that being good enough to a position where people have to exit a system. The other criticism, I think, of shared care has been the fact that a lot of patients in shared care never didn't actually engage with the provisions or the psychosocial provision on offer in secondary services. So it's gradually whittled away over time. So it is quite hard. But what's happened with the divisive commissioning, I think, as well, is we're now in a position in some of our London boroughs where GPs will not provide continuing antabuse and camprosate to stop people relapsing back into their alcohol use. We're in some of our boroughs, we're in positions where if we ask for a blood test to start prescribing these medications, the GPs will say, well, we're not commissioned to do that, so you've got to pay for it yourself. Whereas this would have been accepted as standard practice years ago.
Come on just a little bit more about workforce, because we've heard evidence from the Royal College of Psychiatrists that there's been a 24% fall from 95 to 72 in the number of NHS consultant addiction psychiatrists between 2011 and 2017. So I'm just wondering if any of you would like to sort of comment a bit more about whether this is primarily around recruitment, training and retention. It's a little bit more about the specialist workforce.
What's happened is within addiction psychiatrists do medicine and then they do psychiatry and then they have a specialist endorsement in addictions. They can only get those specialist endorsements in addictions if they work in a unit that offers them supervision and training by another addictions consultant. So as services in the NHS have disappeared, I think there's probably between 10 and 15% left.
It's about 30.
Yeah, as have disappeared. Oh, I'm talking about England. Yeah. There are fewer consultant addiction psychiatrists to actually supervise the training of the next generation of addiction psychiatrists. So that's where fundamentally there is a huge shortage of addiction psychiatrists who will be coming through the system. And I think this is a serious workforce issue because, again, I've touched upon the complexity of the patients, the loss of skills in the sector, the fact that if this generation of addiction psychiatrists grows, there will be nobody to train the next generation. It is a crisis.
Right. And do you want to come in as well on this?
There's nothing really I can add to that. I completely agree. It's
Really, we are looking at there being absolutely no facility in the near future for future training. Is it that bad?
Well, I think it's probably compound. It's that there's no facility for people. There's hardly any facility for people to have the training, and also for the trainee, there aren't posts for them to train to move into. So, quite a number of the consultants who trained with me. So I'm at the end where I'm sort of falling off the end of the sort of career bit. So it doesn't matter. But really good addiction psychiatrists, that I would happily know that a friend or a family member was in treatment with, go through the strange process of having committed to the NHS, then being TUPE'd out to a third sector organisation, and then thinking this isn't really what I thought I was committing to when I made this choice, and they take early retirement. And you've got huge losses from the treatment system.
Can I ask how much, Aaron, do you think it is that point about that you're no longer going to be employed by the NHS that is a disincentive to people coming in alongside the difficulties you've raised about having the specialists there to train them? Is that a disincentive?
I think it's a massive disincentive because people who go into training in addiction psychiatry know that the jobs over their life cycle are going to be quite chaotic. They're going to be moving from provider to provider. And against a backdrop of cuts reducing year on year, it's not a pleasant environment for them to go on to because they're holding increasingly a higher level of risk.
You lack the infrastructure you get with an NHS trust. Like just that depth isn't there. So it's, I think, very unattractive. And you can, if you think in terms of TUPE cycles, not necessarily specifically of doctors, but in terms of services that we've worked with, there's individuals who've been TUPE'd 4 or 5 times to 4 or 5 different organisations.
Thank you. Ben, coming on.
Yeah, just finally, I know we asked you to talk mainly about treatment here, but I just wondered if you had anything to add to the previous panel's comments. I don't know if you heard them about the kind of general picture and whether we can learn from international practice any models of decriminalisation, public health approach, etc., that you think are attractive and that we might like to highlight in our report?
Yeah, I mean, I think we should do what we do with any other area of healthcare. We should peep over the garden fence at what good research is being done in somebody else's garden and then look at, is it applicable to what we apply here? A lot of the examples that were given in the previous session were good illustrations of that. You then sometimes have to check, is it exactly the same in a UK context as a North American context and things like that, but some of them are directly transferable. Professor Hickman was making the point that we can be guided, even government decisions or criminal justice decisions could be studied better. And they only it's exasperating when you see the changes that government or the criminal justice system makes, and it won't allow you to study it. But there's like such a fear that what if the results showed that we'd made a mistake? And my own view is, I have to say, I will vote for somebody who said I will change my position on the basis of the evidence that comes out. And changes of the... we had it in this country with cannabis that changed its classification and then changed it back again. What an exquisite opportunity to have studied what impact did that make on population levels of use and the harm that resulted, and we haven't got the evidence. So you'd need a commitment to the fact... Ben Goldacre's argued this very much more skillfully, but that you can apply science to that, but you have to be willing to suspend your judgment. You obviously have a hunch which is best, and it doesn't have to be a randomised trial. Your point was perfectly correct. There's some things you can't randomise, but you can do one of the designs that's called a stepped wedge trial design, where you say, okay, we'll roll this out quarter by quarter, and therefore we expect to see the benefit appearing quarter by quarter, and we can compare regions or counties that haven't yet done it with counties that have. So I think the more we moved towards that, and health is probably where we've got the strongest experience, public health and individual treatment health. But I thought the answers they gave were very good.
Anyone else like to add anything to that? No, thank you.
Thank you all very much for